So we are going to start the session as it is 1 p.m. And we are going to start with some housekeeping and introductions as more people join the webinar. So welcome to this Meet the Experts webinar. Today's webinar is focused on laboratory errors, and it will involve a presentation followed by a Q&A session, and then at the end we'll have a feedback poll. Your microphone has been muted for the duration of the webinar, and as you may have noticed, is going to be recorded and will be available at a later date on the SHOT website. There is no chat facility during this webinar, but if you have any questions, we invite you to put your questions on the Q&A, and we aim to answer them throughout the session. Please add all of the questions that you may have, as this is the opportunity to make the most of the expertise that is available today. We have enabled captioning from the back end of Zoom. So if you wish to turn this off, you can select hide captions from the toolbar. Without any further ado, I will move on and introduce the speakers. And today we have Nicola Swarbrick and Victoria Tuckley. They are SHOT laboratory incident specialists. We have Pete Baker, that is a SHOT laboratory working expert group member and the Transfusion Services Manager at Liverpool Clinical Laboratories. We have Heather Clarke, that is a SHOT laboratory working expert group member and the RCI Development Lead for NHSBT. And for the Q&A, we'll have also Kerry Dowling, Jennifer Davies, and Robbie will be part of the discussions. I also want to thank Raquel and Fahim that will be providing admin support throughout this session. And I'll pass you over to Vicky. Thank you.
Hello, thank you everybody for joining today. So just a brief overview of how we're going to be doing the webinar today. So we're going to have a summary of the SHOT data from 2023. That'll be followed by some case studies, and then hopefully we'll have a lot of time left at the end for some nice question and answers from you to get your burning questions to the lab experts. Fab. So this is the summary data for 2023 reports. So in the laboratory chapter, we had 535 errors and 207 near misses. So this was an increase on the previous year. And unfortunately, we're seeing a little bit of a concerning trend with laboratory errors, whereas we look at the amount of error reports reported and the ones that were transfused to patients, the proportion of those that are coming from the laboratory, unfortunately, are increasing year on year. So it's a bit of a warning signal from that. Thank you. So this is the breakdown of the laboratory errors from last year. So these are the steps in the transfusion process in the lab where the error occurred. So we go right from sample receipt and registration, which is booking in, through to testing, component selection, labeling, availability, and handling and storage. So this is quite a normal distribution for the lab, but I really want to draw your attention to the testing errors. So unfortunately, this is the largest proportion of errors that we see within the laboratory year on year, which is a little bit of, it was a confusion to me when I started at SHOT, because testing is our bread and butter in the laboratory. It's our area of expertise, but unfortunately, it's also the area that we make the most errors. We see the most of these are specific requirements not met errors, and they're here highlighted in this box here. So these are the main area of errors that we see year on year. And unfortunately, like the lab errors, the incorrect blood component transfused, specific requirements not met errors are going up in proportion every year. So I think 29% of our reports were specific requirements not met errors last year. So these are things like where the testing has been incomplete. We've got inappropriate use of electronic issue alongside other things like not providing phenotype matched blood when it's indicated and not providing irradiated blood when it's indicated. So these are our fundamentals of practice and things that we maybe need to be looking at within our policies and procedures for getting that knowledge embedded. Fab. Thank you, Nikki. If you need any help with your specific requirements, policies, or any guidance, if you're a bit unsure yourself, SHOT have got a lot of resources to do with specific requirements. So we've got some SHOT bites, we've got a safety notice on specific requirements, not met errors, and we've also got a SHOT bite on the use of the SPICE system, which is provided by NHSBT. So I'm afraid that this only applies to people in England, but that really helps look up patient antibodies if you don't have access. So that's all there contained within our IBCT cumulative data page. Wonderful. The last bit I'm going to cover today is ABO incompatible transfusions. So unfortunately, these are still occurring. These are all the ABO incompatible transfusions, the ones that occurred in the laboratory and in the clinical area over the past 10 years. But unfortunately, we're not really seeing any real reduction recently. In 2023, we had 3 from the laboratory, and those are the plasma ones you can see there. They were all due to component selection errors, and there was 1 historical wrong blood in tube that contributed to that. But going right back to 2018, that was the last time we had a red cell incompatible transfusion from the lab. From that point onwards, it's all been plasma component errors, so giving group A FFP to patients who are not group A. So this is an area that you might want to look at with maybe within stock organisation or within the fundamental knowledge within the laboratory about appropriateness of group A. Fab. So I think that's the end of, oh no, it's not. I've got some resources to help you with. Lovely. So the lots of these areas that I've talked about can hopefully be detected before the component exits the lab. So we've got a couple of resources within SHOT to help you with that. Then in 2019, we had the component labeling exit check. This was more of a mental check. Go through, does my component meet all the requirements? Has it been stored correctly? And have we got clear communication with the clinical area that it's ready? We also then in 2022, we launched the pause checklist, and that takes you through slowly, step by step, about patient identification, authorization of results, unit details, component selection and expiry. So they're all there to help you, that little mental checklist before the component leaves the lab, and hopefully this will help you with error reduction. Fab, so I'm going to pass over to Nikki now, I think.
Thank you very much. Yeah, so following on from all the things Vicky's just said there, we're going to talk through some of the key messages from looking through all the reports. So obviously we get around 4,000 reports a year. About 20% of those are due to laboratory errors. And Vicky and I look through those, and we read every single report. We trend, we look for errors, we look for common themes, we look for particular patient groups that have started to emerge to be issues in certain areas. So when we look, there we go. When we look at the common error category, as Vicky was saying, you could see its specific requirements not met, and Vicky outlined that a big chunk of those were things like in the testing area, so not electronically issue when you shouldn't do, not completing testing, and a big chunk of those were not completing panels before the units were issued. So there are 2 big common error categories and common steps during the process. Sadly, we do still receive reports on major morbidity due to laboratory errors. These from the 2023 report were due to sensitization to the K antigen. So I think there were 3 in this year. I think there will be 3 the previous year as well. So this is where a patient has received K positive units and unfortunately has gone on to develop anti-K, which we would absolutely class as a major morbidity due to the seriousness of the nature of that antibody. We did sadly also have a death due to laboratory errors, where the lab in the hematology lab contributed to that error, contributed to that death, sorry. It was a new acute leukemia detected over tea break time when there was an inexperienced BMS, unfortunately left to lone work, and they didn't follow the correct pathways, and the results weren't actioned in a timely manner. The patient didn't receive chemotherapy as an urgent request, and they didn't receive the blood components they needed either in a timely manner. So unfortunately, that did lead to the patient's death. Staff knowledge, we can see this is a recurring theme. Many incidents are related due to insufficient knowledge. This is not just in the lab, this is in the clinical area as well. But we do see gaps are starting to appear in knowledge. And when we look through all the reports, Vicky and I will also pick out any contributing factors. So we will note things like staff shortages, which is a recurring theme and continues to be when we look at the data for 2024. Poor skill mix, so you might have the right numbers of staff, but you've not necessarily got the skill mix you need to maintain a safe system and a safe service. Lone working, we do see an awful lot of issues occurring when a staff are lone working, that additional pressure, that out of hours pressure, gaps in education, ineffective IT. Obviously, there's lots and lots of IT being implemented out there, but we do start to see that gaps in those processes are leading to errors. Communication issues, that again, is not just a lab error. We do see that between lab and clinical areas, or between clinical and clinical if they're like a shared care type of situation, and a poor safety culture. So where staff don't feel safe to bring up any concerns or any issues, and that definitely contributes to errors. So what other kind of contributing factors? We've got cognitive bias. If anybody's ever taken part of any of our human factors courses, you'll have heard us talking about cognitive bias, and that is making absolutely important. Cognitive bias gets me through my day, but unfortunately it can lead to errors. It does leave us prone to making assumptions, and that can lead us down a path that's not, that doesn't lead to the right answer and can affect the patient's outcome at the end. Alert fatigue. Again, we see this more and more, particularly in the lab where we are introduced. We've got lots of IT systems, really helpful, really important, and all of them have an alert when something's going wrong. But often those alerts either aren't clear enough. There might be too many alerts appearing. We see an awful lot of issues coming through to us where there are alerts in place, but they've been overridden. So sometimes they're too easily overridden without any actionable there needs to be an action associated with that alert. So we do see alert fatigue as increasing as well. So another gap or a weakness in the process is a handover. So one of the things we really recommend is having a really robust handover. That might it's not necessarily between shifts, it might be between tea breaks and dinner breaks. Anywhere there's that crossover of staff, and you're making sure that you hand over the right information and in a timely manner as well. So we do have a couple of resources on the shop website about handover documents, and that is one of the things we're looking at as well for the 2024 report. Shared care, as hospitals and patients become more complex and patients are being seen over multiple sites, we do see shared care increasingly as a contributing factor to errors. Obviously, patients are quite complex, their needs are complex, their requirements, particularly if they're on different types of medication or drugs, or if they're undergoing certain types of treatment. So we absolutely see shared care when we're looking through those reports as well. So this is, we're going to go through all the issues contributing to those lab errors as well, probably things that you will have seen yourself. So gaps in staff knowledge and training. So staff fulfill all the requirements, they go through their competency, they tick the boxes that are required, but they don't really know why they're doing it. They know the how to do it, but they don't really know why. What is the consequences of me not meeting this requirement? What's the consequence of me not actioning in a certain way? This is not just this year, we see this on a recurrent theme, staffing issues, so vacancy with recruitment and retention. I'm sure you're seeing this in your own trusts. Excessive training burden left on the remaining staff. So you've got new staff coming in, you're doing all you can to train those staff, probably to get them onto a shift pattern, and that puts excessive training burden on the staff that are continuing to try and maintain their service as well. Staff delivering and training not necessarily having the necessary expertise to do so. There's an awful lot of available training out there, but what we've started to see increasingly is that those gaps in people's knowledge, if you are then required to train somebody, those gaps perpetuate themselves. So you will build, unfortunately, a group of staff who all have that gap in knowledge. Lack of time to complete specialist qualifications, staff needing time for extra training when they're appointed, worsening that issue. So new staff coming from university, not necessarily having any knowledge in transfusion. It kind of depends on what degree they've done, but there's a real gap in that, and that seems to be getting wider, where you're needing to train more staff to fulfill the requirements of the job. And that leads on to the lack of transfusion theory in undergrad degrees, which is being addressed, but maybe that will be talked about in our Q&A session later on. Transfusion topics deprioritised during your BMS registration. So transfusion obviously is so complex, but sometimes it gets a small piece of that pie. When you're looking, if somebody's being trained to cover both haematology and biochemistry and transfusion, sometimes transfusion doesn't always get the section of the pie that it needs to. Changes into IT. Obviously, we would encourage people to introduce IT wherever possible. It takes out the potential human factors, but what we do see is that changes in IT puts an awful lot of pressure on the remaining staff, and staff to introduce the project, staff to validate the system, and staff to continue that training. And as more IT comes in, that will be a continual hamster wheel. Yeah, challenges with the recruitment and retention, mainly at band 6, so it's just constantly struggling to keep people on the shifts and maintain that service. This is from the 2023 report, so we're still talking about post-pandemic pressures. I don't think that necessarily has gone away, which has increased the workload. Abbreviated training, so maybe to allow us to get people on the shifts or to allow us to people to be lone working in some way. We've some trusts have abbreviated the training, they've simplified the training, and it's just not broad enough or wide enough to fulfill all the knowledge that's required to do the job properly. Poor safety culture. We will go on and talk about UKTLC later on, but obviously that not having a system in place where you feel confident or competent to raise any concerns, or you feel like if you do, those concerns aren't taken seriously, or you don't get any feedback on those concerns, or you are discouraged to raise concerns, all impact on your ability to do your job. And again, this kind of follows all of the above, really, that increased workload and mismatch of work. A mismatch of staff to do the work, unfortunately. So we have 5 lab recommendations from 2023, and these all follow on from what Vicky was talking about before. So patients shouldn't die or suffer harm from avoidable delays. What we are seeing, and we will continue to see in the 2024 report, which obviously isn't available just yet, but those delays due to the labs is increasing, it is an area of concern. So where your transfusion needs are complicated or complex, staff need to be able to have some sort of provision of advice in whatever format that takes in your hospital or organisation, but you need to have you need to be able to be provided with that advice. Staff must have protected time for training and education to make sure that you're meeting the needs and the requirements of your department and your service. This third one was we were thinking about when new IT and new big projects are being implemented, that the ideal will be to have a bespoke operational role. So not just having to maintain your day job, but having an additional role where you could focus on that project and see it through to completion at a high standard and a high level. And policies for lone working. So we are starting to see that lone working impact on reports. Excuse me. So what we were just trying to recommend here is that if you can reallocate any tasks out of when people are lone working, whether that's a weekend or a night or an evening, take them out and put them where there's more staff available, and really review your workload to staffing numbers wherever possible. And this is the clincher at the end, the just and learning safety culture, just making sure that you provide that support and that safety net for your members of staff and the impact that has on the patient. So we didn't want having a poor safety culture to then lead on to worsening recruitment and retention issues in the lab, which unfortunately we'd started to see. So we have got some cases, because I think it's really important for us to give you real cases. It makes it much more memorable. What the cases are all anonymised. They are when they come to Vicky and I, when we look through them, and they're all based on information provided to SHOT. They are representative of data, and so there's no details on there that you will be able to identify, hopefully, and they're for educational purposes. But I'm hoping they will help you understand all the things we've just talked about in a few cases. So I think I'm handing over to Heather.
Thank you, Nikki.
Thank you.
Okay, so the first case is the case of a female in her 30s that was found to have an anti-K as part of her antenatal screening. She had required 2 units of red cells post-delivery in a previous pregnancy due to active bleeding, and one of these units was since found to be, that was issued by the BMS, was found to be K positive. The LIMS in this organisation did have an alert for all females less than 50 years of age to state females of childbearing potential should receive K negative red blood cells unless they are unavailable in emergency, but this did not prevent the issue of K positive red cells to this patient despite the availability of K neg units. The investigation stated that there was a lack of knowledge in recently qualified BMS staff in the laboratory about K negative requirements, and that continued recruitment and retention issues had also placed a training burden on the remaining staff. And additionally, there were leadership issues due to changes to restructuring in the organisation. So this case illustrates the importance of having a thorough training plan in place for all of your staff, and actually the time to train them is also key. And competency assessments that are drawn up must cover all areas of the transfusion processes covered by the laboratory, and it also highlights the importance of laboratory capacity planning. So the next case is a patient with a thalassemia who received red cells which did not match their Rh and K phenotype. So the specific requirement for phenotype matched was actually recorded in the LIMS, and an additional step to highlight this in the patient notes field was not completed, which then resulted in the BMS dealing with this case not selecting the correct phenotype matched red cells. During the investigation of the error, the BMS stated that they were multitasking and also rushing, and the event happened at weekend when there are much less staff available within the laboratory to assist. The report also stated that staff do not have the correct amount of protected time to develop their knowledge and skills and are less prepared to deal with these complex cases when they arise. The BMS felt they were being watched and there was a blame culture within the laboratory. Leadership and staffing issues within the laboratory had already been reported. So, as well as issues with staffing capacity, this case shows how a blame culture can contribute to unsafe practice. The UKTLC and Shock Culture Survey in 2023 showed problems with instability and staff not feeling safe in the lab, and this was impacting on their home life and health. It also showed that in some cases, people weren't reporting patient safety issues due to the fear of being reprimanded. Next slide, please. A summary of all of the survey findings can be found on the UKTLC page of the SHOP website, alongside documents with ideas of how to improve safety culture within your organisation. As well as the surveys, there's also access to the standards and other resources, such as examples of capacity plans that you may find helpful.
Thank you, Heather. We're going to look at another couple of case reports that have come in different aspects of laboratory practice. This one is around a patient who has neutropenic sepsis on the haematology ward who required a unit of platelets. There were two patients on the ward who had the same surname and both had the same blood group, and the platelets were ready for collection on the agitator. They had a electronic blood management system on the site, and the platelets, the person who came down for platelets collected the first one, and there was an alert to say, stop, contact the blood bank for advice. Advice was sought, the lab reassured the staff and advised them that it was fine to take the unit. The unit was taken to the ward, but the patient developed pyrexia, and so the platelets were returned to storage, where a second alert stated the unit should be quarantined. Later on, a second nurse came down to take the platelets, and a third alert to stop contact the blood bank, again, because the unit was unsuitable for use. Again, they asked the laboratory for advice, and again, they were told it was okay. The unit was taken to the ward, and a two-person independent check did not identify it. This kind of shows the importance of reading the alerts. And I know Nikki spoke a little earlier about alert fatigue, but we need to try and minimize the amount of alerts that we have within our IT systems, but make them very pertinent. But with this one, you can also ask when whoever came to collect the unit of platelets, what did they actually have to identify they were collecting from the right patient? And again, it did fail the bedside check. So although the initial errors were at the laboratory with poor advice, there were opportunities later on to stop that unit being transfused. Thank you. So this is just a highlight script, which is a learned group of individuals from clinical, nursing, lab and IT backgrounds. And their sole purpose is to improve transfusion safety through improving in IT systems and processes. If the QR code will take you straight to this page, and there is this is where you'll open up the using information technology for safe transfusion. If you click onto this, the document goes through the 10 stages of the transfusion process and indicates where IT, whether it be electronic patient record, whether it be LIMS, whether it be order comms, how that plays importance into each of these steps. Thank you. There's a number of resources within the script web pages. I want to highlight this one, which is the IT toolkit. These have got sample documents about a LIM specification and validation plan. It's also got sample documents for ORDERCOM specification and validation plan. These will be updated as more documents become available so we can share. And the idea of this is that we move forward by sharing best practice. So yeah, thank you. Next slide, please. So this is very pertinent, perhaps at the moment, about IT downtime. There's a document within it, which is an aid memoir, which guides you about things you need to consider to put into place. So if there is an IT downtime, you are ready and can apply it. So it goes into suggesting about having a high-level business continuity plan, risk assessments, contacts, which is really quite important, and policies and procedures. But other things you need to consider is downtime. If it's only going to be a short downtime, that is a different procedure than if it's going to be a lengthy downtime. And then further actions to consider in your business continuity plan are things like regular testing to make sure that your system is fit for purpose, should you have it, and also recovering the information once your systems are brought back online. So this is something that I want to point out is lessons learned. Again, moving forward, we only move forward by learning lessons and sharing good information. Any good project should have a lessons learned part of it. And I would encourage anybody who's gone through installing a piece of IT solution, whether it be a LIMS, whether it be electronic blood management, whatever it is, if that could be shared with SHOT. As with SHOT reports, I think you mentioned earlier, these are anonymized and they are handled sensibly and are purely for an educational purpose. Thank you. Okay, so this is a second case I've got, which highlights knowledge, skills and competency, which Heather mentioned before as part of the UKTLC standard. So a sample was received from a patient requiring transfusion post-operatively, and the BMS was lone working in the laboratory over a weekend. The analyzer flagged that the sample was hemolyzed, but the results were accepted by the BMS rather than being rejected because the BMS didn't know how to reject a hemolyzed sample. There was no results in the patient's reverse group, and the BMS inappropriately amended the results to a 3+ to give them the group. The LIMS excluded the patient from electronic issue, which is correct, and highlighted the requirement for a serological crossmatch due to the modified group. But the BMS was unaware that the modification would have a negative impact on this, and it deselected the electronic issue and entered a negative reaction into the crossmatch results, even though no tests had been performed. Although the BMS was deemed to be competent, they were bank staff who did not routinely work in core hours and were previously employed as a transfusion BMS within the organisation. So I think the belief was that they were suitable to be able to cover this shift. It does highlight the knowledge and skills gap that was mentioned earlier on. And again, if we're looking at training policies, we really need to think about how we handle the unexpected rather than the expected. So if we're looking at training staff to be able to do group and screening, they need to also understand how they would handle anomalous results. Thank you. So again, this is a learning point, but is part of the standard from the UKTLC about staff should have, this is all staff working in transfusion, should have a minimum of 10 days of routine work within the laboratory so they can be informed of changes in practice and receive appropriate support from their supervisory staff. And again, part of continuing professional development would require this. Thank you. So in 2023, following an incident that was reported to SHOT, SHOT worked collaboratively with UK NECWAS to have an exercise and a survey to understand uninterpretable ABO groups. So the report highlighted gaps in practices and staff knowledge, and it was quite clear that the incorrect interpretation of dual populations of blood groups and LIMS functionality were the key reasons for this. If you scan the QR code there, it will bring up the summary of the report survey, which you can see a little infographic there, but also brings up information about good practice for managing indeterminate blood groups, and also the NECWAS and SHOT reports in the UK. So not everything's doom and gloom. This was an ACE, acknowledging continuing excellence, where a BMS identified a mixed field result within a D group for a pregnant woman. This happened at 35+4 gestation. So this prompted the BMS to contact the clinical area to have an understanding about additional information, and it highlighted the risk of large fetal maternal hemorrhage. The patient was brought back to hospital for scanning, results of which were suspicious and resulted in an early delivery of the baby the following day. Baby was very anemic and required red cell transfusion. If it hadn't been for the presence of the BMS escalating this, the mother may not have been assessed and the baby delivery might not have been as successful as it was. This was reported locally as a grade 6 and was rated within the organisation and acknowledged the prompt action of the BMS, who has worked and also received acknowledgement throughout the pathology network. Thank you. So again, there's a QR code there. This takes you to acknowledging clinical excellence, and that the SHOT definition of that is exceptional transfusion practice by a team or department that was above and beyond the routine practice and has widespread learning and opportunities. So like before, when we were talking about lessons learned and ACE reports, that we really need to understand what is good, how we can learn, what we can do better, either by understanding how people have got over hurdles within their systems as they've been developed, or the additional practices brought back superb results. Thank you.
Fab, thank you very much, Pete. Just before we get on to your questions, I've seen loads coming in. Thank you so much for interacting. Just to let you know, registration is now open for the annual SHOT Symposium for this year. It'll be on the 11th of July in Birmingham, so hopefully a nice central location for everybody. If you have any learning to share, if you've got anything you want to tell us in an abstract, the deadline for that is the 18th of April. So we have lots of opportunity to promote your work through that. And also we have a reciprocal arrangement with BBTS, which means that if you're presenting anything there, you can also present it to us, which is good. Of interest might be the fact that we've got a limited number of free bursary places. So these are open to anybody working at band 6 or below in junior grades. We've got an application form. So when the deadline for that has passed, we'll review them, and then that will be before the early bird fee deadline. But anybody working at band 6 or below with manager's approval can apply for a free place. If you want any more SHOT webinars like this one, the next one we've got coming up is our paediatric Meet the Experts webinar, and I believe that's on the 9th of April. So that is the end of our webinar. I've seen some questions coming in, so thank you very much. Please continue. We'll be here for the next half an hour for a Q&A session. So thank you very much.
So we'll start the Q&A session. So thank you for the questions that have been put. And if you have any question, please add it to the Q&A. So the first question that we have is, should we be auditing or reviewing and recording in the quality management system the fitness of staff to train others? So if all panelists come, thank you. And who like to take the first take of this question?
Can I take this? Thank you. Yes, I think it's a good starting point to mention the good practice guide. That gives a lot of guidance and advice on the requirements that need to be put in place for your quality systems. I think there's other questions coming up later regarding staffing, but you need to familiarise yourselves with Chapter 2 of the Good Practice Guide. Just reading the first couple here. The first one, personnel must be available in sufficient numbers to carry out activities related to the collection, testing, etc. And trained and assessed to be competent to perform their tasks. Now, training is a task that is required within the laboratory. And so, yes, they need to be trained and competent to be able to do that as part of their day-to-day job, to pass on that knowledge and training to the members of staff in your laboratories.
Can I just add, to the question about, so say about auditing staff, I think it probably does sound like a good idea, because we all know how things happen sometimes if somebody steps in because there's nobody else, and then that eventually becomes their role. And if you feel like you've got a particular gap, that might be a start tool to be looking at it. But it seems like a sensible suggestion, but obviously there's a large burden of work out there already. So if it's something that you're seeing that you might have a inkling of, doing an audit would really give you that oomph and that evidence.
Yeah, and I think if I can just jump in a minute, I think in one of the cases we looked at, it was very clear that cascade type training isn't always effective. So you do need to know exactly which staff have got that advanced level of knowledge and skills, to particularly the knowledge aspects, to be able to pass on to other staff members. So yes, totally agree. It's worth checking and making sure you know who can train, who does have that level of knowledge in your organisation to be able to train.
Can I ask the next question then, because it does follow on from that? And there's quite a lot of questions about training, so I'm hoping this might cover a few of those. Is there a UKTLC or other standard for basic knowledge requirements for particular bands of BMS? Might throw that one to Kerry and Jenny. Please.
Sorry, everyone. There's an appendix in the standards that talks about the education level that we would expect certain levels of BMSs to have, so band 7 and a 5 and 6. So if you look at the appendices on the UKTLC standards, that's there.
And also, I would encourage everybody to audit against those standards as well. And there is an audit tool available that you can use as well.
We actually made that a KPI, how many staff in our service meet the requirements of the UKTLC standard appendix. It gives you a measure when you're looking at training and competency. So it's also quite useful. You can report that back or report up if required, if you're escalating issues.
So thank you. So moving from that question, it says, do you feel accelerated training has impact on laboratory errors?
I'm happy to speak to the shop data on that. I can say it's quite tricky because it's subjective. We don't have a definite defined matrix for it, metric for it, get my word out, but we do see it mentioned. So when we're reading through the cases, we see an awful lot of mentions of we've been trained and we've got through a certain number, which is getting really worrying, that we're seeing quite a few people with the recruitment retention issues to get people on shift. Those people have kind of developed some mandatory and non-mandatory competency assessments in certain places, which seems slightly worrying trend, and we are seeing it mentioned more and more of rushing to get people on shift. And you can completely understand why it's happening, because there's just not enough bodies in the lab, but we also need to obviously make sure that people are doing it safely. So that's the long way of saying, yes, we are seeing an impact, but I don't have the crunch of the numbers to give you, and it might be something that we might be worth looking at in future years.
Sorry, I was trying to turn my microphone off. Yeah, so following on about UKTLC, we've had a question. Would you consider distributing results back to labs about the UKTLC staff survey, a bit like the NHS staff survey, to see how their own departments can feel, how they're feeling, see how they're feeling? Part of that question is, I suppose it was completely anonymous, so we wouldn't know who to feed that one back. But that doesn't mean you can't take those things locally and create your own survey if you really wanted to know how your own departments were. I don't know if Kerry and Jenny want to add
Nikki,
to
just
that.
to add to that. So as part of doing this survey, we said that this would be anonymous. So we told participants it would be anonymous, so it would be wrong of us, even if we did know, to feed back to Hospitals Now, who said, what? That's not appropriate. And that enabled people to feel safe and come forward and tell us what they were experiencing. But one of the recommendations is that you do a local culture check yourselves. So that's how you will get the detail for your own individual laboratories about what the situation is for you in your lab today. And it will be different everywhere. So it's really important that that is done. And we recommended that it was done by an individual who maybe doesn't necessarily work in the lab, so an independent person that people will be comfortable maybe talking to.
Thank you. There's another question about the safety culture. So do you think there has been an increased awareness in the impact of having a good safety culture on laboratory areas following the UKTLC survey? And how else can we improve the safety culture? Any tips or suggestions?
It's quite a big question, isn't it? So we would hope that people are more aware. We've done some roadshows, we've been around and shared the findings. The findings were shared with the CSOs. So this has been escalated quite a lot. In terms of what do you do? Well, that's a huge question, and there are lots of resources on the SHOT website that you can go to. I'm also happy if you want to reach out to me. Expect Jen, I don't want to speak for you, but the UKTLC in general, if you've got a specific question or you're struggling with a specific part of this and you want to reach out to us, then please do. We'd encourage you to.
Again, mine's going back to staffing numbers. And it kind of covers a few again. So there are a couple of questions in there about staffing numbers, just a couple of comments saying how hard it is out there. That's not just the lab, the clinical area as well. Absolutely. I couldn't agree more. One of the questions is, what do you think we can do to start addressing these staff shortages that people are experiencing? And I mean, I know there's no magic answer, and somebody has put that. They do realize that there might not be an answer, but what do you think as a panel?
Can I answer that a little bit? I think one of the things which is important that we actually need to go back and review our workforce. I think we got into a situation over the last few decades where we were just filling all the resource requirements with Band 6 BMSs, and there's a lot of tasks within the laboratory that can be handled by low grade staff, perhaps a Band 4 associate practitioner. So I think that's a potentially good start. I appreciate that everyone's having challenges with recruitment and retention of staff, but I think if we can't get the staff to meet our capacity plan, we have to look at the knowledge and skill of each of the tasks required and then assign staff appropriate to that task level.
Can I just add to that, Nikki? Sorry. And you need to even go back further. So the university courses, they need to have more transfusion knowledge on them so that when these students come out of university, they get more of a feel for what transfusion life is about, and they may feel like they want to go into that. And then when they do come in the lab, they've got more knowledge, which does accelerate their training a little bit because they've got more background knowledge to come in with from the get-go, which we don't see at the moment.
And also going back
Sorry,
even further into schools. So we need to attract people into the profession for the future, and we need to capture them before they hit university so that they know what they require, what degree they need for registration if they decide they want to go down the biomedical science route. So there's a lot here about attracting people into the profession, making sure the education is out there so people know what they need. And going into schools, colleges, etc., all pieces of work that have sort of started happening.
Yeah, I would also,
sorry, Jenny.
No, sorry, I would also put into that about growing your own staff as well. If you've got people in support roles who have got the relevant or nearly the relevant qualifications that they can do top ups and get them through the registration portfolio, that's a really good route to go down. And also picking up on some of the things Pete said about tasks, there's a lot of it as automation of the things that you can automate within your labs so that it's not so labor intensive, and looking at electronic solutions to some things that are maybe being done on paper or manually at the moment.
Yeah, I suppose part B of the question is if we had enough staff in the pipeline to implement them in or to to start them on the road of being a transfusion biomedical scientist, there are other questions related to funding. Obviously, Jenny kind of answered that there about IT and might be able to get the funding. Has anybody got any comments about the funding of staff?
Not about funding as such. That's, somebody else can answer that. But going on from the previous comments, I think, excuse me, my cat has decided to join us. So I'm not going to answer the question about funding, but there's no one single answer, as we've heard from the other panelists. And part of the question, part of the answer is what do you do with the resource that you have available? Going back to what Pete said, looking at the tasks and the workload, review your capacity plan, find out what needs to be done at what time. Can you balance the levels of staff that you've got against the level of work? Can you change the level of work? Speak to clinical areas. Do they need to send their samples in at a particular time? Can they send them earlier or later when your staff are there? Look at your policies for taking breaks, taking annual leave at the same time, so you've got staff in the laboratory at the time that you need them. Yeah, that's just one other answer. I know it's not going to solve everything, but it's part of the bigger answer.
Thank you. So the next question is lone working impacting on errors?
Can I take that one again? I think, again, it'd be too easy to say yes. I think it goes back down to capacity and balancing the work. I think, you can have 2 or 3 people working, but if the workload's too high, it's going to lead to errors. So it's not just about lone working, it's about balancing the number of staff and the work that you have available. You may have a lone worker where the workload isn't so high, and that isn't a problem, that's not a risk, but it's the imbalance between the staff that you have working and the workload that you have to do.
I think
Sorry,
sorry,
Vicky.
Pete.
I was going to say, I think it's also difficult to assess that, because if you've got a laboratory where they have core hours, and outside of core hours you're down to 1 BMS, 3/4 of your week is then covered by a lone worker out of hours. So to say that there's more in 3/4 of the time is quite different. I think the shot data is around 30%, Vicky, thereabouts, but 30% of 75% of the work may not necessarily be reflective of an issue with lone working by itself.
Thanks, Pete. Yeah, and I was just going to add we've mentioned about capacity plans and just making sure that they're reviewed, because the NHS is changing. It's becoming less and less routine hours of the day where things get done, and there's more clinics, there's more things open at the weekend, and my GP surgery opens till 8 o'clock one night now, which is great, but means that there's more samples are going to be hitting and that out of hours. So I think revisiting your capacity plans to show when work actually comes in, may show that if people are left on their own, not left on their own, if they're working by themselves, there might actually be more workload than what you're expecting. That might need to be adjusted. I know we've talked about staffing and the difficulties, but also when somebody is working by themselves, having proper escalation routes for concerns is something that we see as well, that's not always implemented properly. And just to make sure there's clear procedures and clear lines of escalation if there's any concerns that occur out of hours.
Yeah, and it is really important to have that capacity plan, a really good, robust capacity plan in place, and also to be able to look at your workload as your workload changing over time. So having that monitoring process in place, and also to have the escalation in place if you're not meeting your capacity plan as well. That's really important. And we do have some capacity planning guidance on the website as well, because I know how hard it is to do a capacity plan. It really isn't easy. So we have shared some learning on the SHOT website for that as well.
I think it's really interesting when we look at the report. So the question is, one of the lab questions is, do you have a capacity plan? Yes or no? Most people tick yes. Was it met at the time of the error? Again, most people say yes, but then there's a question later on saying, have you got a disparity between your workload and your staffing? And around 20% of people say yes to that as well. So there's got, like, those don't balance, do they? That either you meet your capacity plan or you don't. So it's after an incident, or like you say, regularly reviewing that and to see the workload versus capacity plan. Sorry, that wasn't my question. So the next question is really, I think it's really interesting. I know effective communication among colleagues can help minimize lab errors. What kind of strategies do you think have been implemented to enhance communication in the lab? Anybody got any suggestions?
Again, I'll take it back to basics. Communication, and I say this often in meetings, communication is a process. Treat it like a process. As all processes, they need to be planned. You need to define what the process is. You need to document that into a procedure so that it's standardized. Communication often is left to being an ad hoc discussion between members of staff. But if you treat it like a process, and it becomes part of your quality system.
I would say there's plenty of tools out there that people might want to implement. There's all sorts of models that you can look at, things like structured for graded assertiveness for those tricky conversations. Very happy that Chris's cat's joined us today. But that makes something once, and it does kind of something that has to be within the organisation, which I know is really tricky. But if everybody's used to certain words and used to certain things, then they get the right alert, if that makes sense, from your voice, from your tone, from your words. But Chris is right, it's something he's got to have thoughts behind it, and having tools like structured handovers that are written, or other things like that, telephone request forms that are written, may help. I know that you've got a lot of other things on your plates as well, but yeah, having something that people are expecting to happen can only help in these situations.
Can I just add, Vicky, the SBAR tool is quite useful for that, for standardized communication, and there's one in the major hemorrhage, BSH major hemorrhage guideline in the lab appendix. There's an SBAR for the discussion between the lab and the clinical area when an MHP is activated. So have a look at that. You'll find it's pretty useful in other areas as well.
Thank you. So
sorry, can I just say as well about communication before we move on? It's a two-way process as well. It is imparting that information and understanding that information. So you need to have that feedback loop, if it's verbal communication or written, to make sure that people are actually understanding what you're trying to tell them.
Thank you. So the next question is going to be about IT. So how much impact are issues with LIMS and their lack of functionality having with lab-based errors?
Sorry, do you want me to take that one? I can get off mute. Yeah, so we do see a lot of errors where IT has contributed. In the IT chapter, we're now also looking at where the reporters have said that IT could have helped prevented the error as well. So we're really trying to have a look at all aspects of IT. Definitely the alerts which were mentioned in the case studies as well that aren't always clear, they don't always pop up in the right place. At the right time for the lab staff. There are deficiencies in functionality in some IT systems. And so, yeah, we're really trying to have a look at that and try and help, talking to the users and the suppliers as well, and trying to build better systems. We did notice in one of the surveys that there are a lot of different version numbers, particularly of LIMS systems out there. So it's possible that labs aren't always upgrading their LIMS. So they may be missing opportunities to get those improvements in. So we do recommend and encourage you to have conversations with the suppliers about how systems can be improved that you currently have.
Thank you, Jenny. The next question, I'm going to summarize. It's talking about PAS systems or EPR systems, changing the patient identification, changing on that process and causing delays and not letting the lab know. So it's just talking about, is there any information on the script toolkit that will about preventing those sorts of errors occurring? I suppose the answer is, Pete talked a bit about the toolkit. It will hopefully be an ever increasing source of information. If you've got information that you think would be helpful for us to put on there, these are working documents from real labs. These are not things that necessarily sort of created. If you think there's something that you've used locally that would be really helpful to others, we would absolutely plug for the script group, but we would love to see it and we can always promote that as well from our end. So any comments about the EPR or the PAS systems changing patients' ID along the process?
Yeah, absolutely. I mean, it does happen. And I think this is all about understanding how your own systems work, how they are interfaced, and make sure that everybody understands what happens. So at the EPR clinical side of things, so that they have that understanding that if they change a patient ID, that might have a knock-on effect in the lab, etc. And it's all about understanding the functionality of your own systems, isn't it? And how they're talking to each other is just really important.
I'm just going to have the last question. I'm mindful of the time. So is the minimum requirement for 10 days working in blood transfusion inadequate to keep knowledge and skills up to date?
Okay, so this sort of was born out of the fact that there were people who were getting no time working routinely in transfusion, often multidisciplinary staff who had no days working routinely. So the UKTLC as a group, when they were devising the standards, is a range of professionals, and we also get peer reviewed. So the standards go for peer review, and it was agreed that 10 days was appropriate. However, people are individuals, so you need to know your staff and know your team, and you might think that actually 10 days in your setting might not be enough, and you may want more than that, but 10 days was set as a minimum from a group of professionals.
I'm going to just add, in line with that, they've also got to keep their training up to date and their competency assessments up to date. So not that they've done it and then they've just done 10 days. This has got to be maintained throughout the year.
Because of the time, if you have any question that he has not been answered now, and it's a burning question, please just send it to Shot, and we'll send it to the relevant expert. And I'll hand over to Vicky now. Thank you.
Thank you, everybody. Thank you for your engagement and a really useful webinar. Hopefully soon we're going to have some poll questions appear on the screen. I think it's only 6 or 7 questions just to help us realise how useful the webinar has been and just a bit about resources. So hopefully they'll be showing up in a minute. While they're loading, I just thank everybody for attending. I think this is some of the best engagement that we've had on a Meet the Experts session, so it's been really useful. And as Vera said, you can send an email to Shot with any last query, so that's shot@nhsbt.nhs.uk. Lovely. So the first question here is just metrics about how people are viewing the webinar. Next one is how useful you found it. Third one just helps us realise who our audience is, so we can tailor it for future webinars. And then the last 3 questions are about making people aware that that we've got a new website, have people now understand a little bit more about the UKTLC, and the last one is about a script. So they'd be really handy to know. I know we always get questions about the recording, and that Vera's mentioned, and so that hopefully will be up on the website in the next couple of weeks. And unfortunately we can't issue attendance certificates, but if you'd like to do a bit of reflective practice, you can enter that into your CPD log as well. Wonderful. So we'll just leave that there for you to fill in for the next minute or so. But I think it's been a useful webinar today. And then I think we're all ready and raring for the new data that's coming out soon. So we'll have new insights in the next couple of months. So the Shot report launches on the 11th of July, the same day as the symposium. Wonderful. I think we can call that to a close. Thank you to the panelists. Thank you to Raquel and Fahim for your admin support, and for everybody who's contributed today. Have a lovely afternoon.
Thank you. Take care.